Good phacosurgery involves preservation of the capsular bag, especially the posterior capsule. And when this happens, that there is a tear in the posterior capsule, the results are compromised. However, we'll see this case where, in spite of posterior capsular tear, the things didn't change as planned. So, this was one gentleman who was planned for his cataract surgery, which was nuclear sclerosis grade 2 to 3, and we can see the anterior segment photograph. And the patient also had a posterior capsular cataract, as you can see in this photograph. A corneal incision, clear corneal incision, has been designed, keeping the incision site at the steep axis. Intracameral lignocaine is injected inside, followed by methyl cellulose 2% viscoelastic material to keep the chamber inflated. In few of these cases with nuclear cataract, we can actually make out that there's an outline which basically gives a very good guidance about the size of the capsular axis, as we can see in this case. Capsular axis has been finished, and now it is time to make a side port. I usually use a MVR 20 gauge to make this side port, which works well for me instead of using a lance tip knife. Hydrodissection has been completed, and now we are proceeding for disassembly and emulsification of the nucleus. Entering inside with bevel down and rotating the tip so that the bevel is up. We are proceeding for a direct horizontal chop technique. The pupil is little fluctuating here, but it is still comfortable to work with. Burying the phaco tip and applying some more power, achieving a direct chop which is full thickness in first go, and then subsequently chopping the nucleus in further smaller pieces. Now here I would like to emphasize that it is always good to chop the nucleus in more than 4 pieces, and this will always be good for the cornea because smaller pieces will always protrude less into the anterior chamber during the phacoemulsification process, and there are less likelihood that they will touch the corneal endothelium, which is usually detrimental, because if the corneal endothelium is touched during the emulsification process, usually it results into endothelial cell damage and maybe a significant amount of keratitis the next day. So smaller the pieces, less are the chances of this damage. We have finished the emulsification of the nucleus, removing the epinucleus also, and now what we are left behind is some amount of cortical matter. Usually it is seen that this is the stage when most of the posterior capsular tears occur. The reason being that one has to work very close to the posterior capsule, and as you can see that there is a plaque on the posterior capsule which is not getting peeled, and so to remove that portion of the cortical matter one has to go close, and these are the situations where you can actually catch hold of the capsule, and because the capsule is fragile and there's enough vacuum in the aspiration tip that the capsule can get torn. The moment this has been realized, the first thing to be done is to release the foot switch so as to stop aspirating the capsule. Minimize the movement of the phaco tip and don't move it or pull it. Rather, the second thing is to be that you keep the infusion on and also inject viscoelastic before withdrawing your irrigation aspiration handpiece. We can here see some amount of tear which is not very obvious at this moment, but it is a small round tear right at the point where the irrigation aspiration cannula was there. Because the bag has been emptied, so we are proceeding for IOL implantation. There is no vitreous at the wound, and we are proceeding to implant the intraocular lens, which is a hydrophobic monofocal IOL. And in this situation, it is better to direct the leading haptic away from the portion where the tear is suspected. And now dialing the IOL in place, and this will also let us know if there's any vitreous prolapsing into the anterior chamber or entangled into the wound, because that vitreous strand would push the IOL away from its natural position. Here we can now appreciate that there's a round opening just in the left hand side of the center of the pupil, which can be seen as a portion where the viscoelastic gel has prolapsed into the vitreous cavity. However, because there is no vitreous prolapse, so there is no need to do any extra maneuver, and the IOL will keep the vitreous in place because we have not done anything to disturb the vitreous. Chamber is inflated and the surgery is done. It's important that the viscoelastic material is thoroughly washed out. This is the day 1 picture which you can see when there is hardly any evidence of any such accident which we had seen during the surgery. And this is the day 7 picture when the patient has been given the diffraction and the patient's vision is 6 by 6 with some amount of correction. Thank you.